A very good evening to all of you. My name is Ashish Chopra and I am from the Medical Affairs Department of Signutra. I would like to extend my warmest welcome to all of you to our advanced webinar series, which is on enhancing pediatrician understanding of the vital role of specialized nutrition in a child's recovery. Before we begin the session, let's start by acknowledging the importance of pediatricians in ensuring the health and well-being of children, as you all play a crucial role in diagnosing and treating various health conditions, including those related to nutrition. Today, we are here to delve into the significance of specialized nutrition in aiding the recovery process of children facing various health challenges. Proper nutrition is not only essential for growth and development, but also plays a pivotal role in supporting the body's healing mechanism, especially in pediatric patients. Now, to take up the session, today we are joined by an eminent and a renowned speaker and an expert in the field of pediatric ICU. Welcome, Dr. Maninder. Let me have the opportunity to introduce Dr. Dhaliwal. Dr. Maninder Singh Dhaliwal is a senior consultant in PICU and Pediatric Pulmonology Department at Amrita Hospital, Faridabad. After completing his MD in pediatrics, he acquired fellowship in pediatric critical care medicine. And his areas of interest are in pediatric ICU, pediatric respiratory medicine, and he has to his credit more than 30 PubMed indexed plus many chapters in Academic Pulse, PICE, and ICU module. And he has awarded a very renowned awards, including James Flett Endowment Award in 2006, also PICU Fellowship Gold Medal Award in 2011, and also Asian Patient Safety Award in the year 2014. So now, without taking much of your time, I will pass on the session to Dr. Dhaliwal to take up the session.
Hi, good afternoon, everyone.
Let me stop share. Now you can share your screen, sir.
Yeah, it's a very warm afternoon. 1 second. Okay. Is it full screen?
No. Yeah, now it is.
All right. Thank you, Ashish, for such a wonderful opportunity, because this is one area where I think there's a knowledge gap versus there was a product gap also. Because many children get admitted in intensive care units, be it for dengue, be it for any critical illness. And when they go home, there's a big gap in the nutrition. Whereas they take the antibiotics, they take many other care of physiotherapy also. But nutrition, I feel, is one area where I'll say most of the specialties, they need to be aware that it is very important for a child's recovery to health. With that, there's a very famous scene that I like to play. It's from a Amitabh Bachchan movie where he's been held hostage by many number of people. So he's the patient over here. And when he's fighting that particular illness, he's fighting sepsis, he's fighting hypoxemia, he's fighting, maybe it's a case of trauma, he's fighting injuries. So he's actually in a very bad state. And on top of that, we give neuromuscular blockades, maybe sedation, antibiotics which have side effects, ventilation. So a patient is being exposed to both the disease and also what we call our supportive management, which makes the patient in a very big nutritional deficit state. He can convert into hypoglycemia, plus in the acute stage, he's mostly NPO, and sometimes we give steroids. So there's a lot of catabolism, which is on one side because of the disease process, and there are a lot of side effects because of many supportive treatments that we are giving. And the patient in between eventually gets tired, and there's something called as malnutrition in ICU, and we all contribute to it unknowingly. And that is where we want to stress. It's not only a patient who's very sick. Any patient who gets admitted in ICU is not necessarily a patient who's on ventilator will be getting all this. But almost every patient becomes tired eventually. And here is the role of nutrition, and it is much more than it was much considered before, because nutrition is required for the patient to fight the disease, fight the side effects of medicines, and convert the catabolic state into anabolism. Let us take few examples that we routinely see. We have a ARDS patient who is on neuromuscular blockades and steroids. He is quite obviously NPO because of high ventilatory settings. Then there's a septic shock patient who is on inotropes, and because these inotropes are there, he's NPO. Then there is a dengue lung patient who is on BiPAP or oxygen support, and again the patient is NPO. And if you see that here, obese patients are more different than a malnourished patient. We feel that the obese patients require special diet as against a malnourished patient who comes into ICU. So we think obesity is like he's overnourished. No, even obesity is a state of malnourishment as far as nutrition in PICU is concerned. Then comes routine post-op cases when we are waiting for the child to get awake. There are minimal settings, but the NPO orders continue. So pre-op NPO, post-op NPO orders, unnecessary NPO orders, just because there's an old age tradition that we have to keep NPO for certain days. Then maybe refractory status epilepticus, which is a highly catabolic state, and the patient is now deeply sedated and analgesia is being given. Again, NPO is being done. A status asthmaticus because he has high respiratory rate. So if we give feeds, he might aspirate. So there are many number of reasons for a doctor not to feed a child. The reasons can be as simple as he is having fast breathing, and can be as complicated as he is having 3 inotropes. So I think so. We are tuned in or trained in that. Give me a reason, and as an intensivist, I will make the patient NPO, or as a pediatrician, I'll make the patient NPO. So this is what we want to highlight, that iatrogenic malnutrition is existing in ICU, and this is a time that we all have to change, because we don't want to feed a sick child. Because as a doctor, I am scared of aspiration, maybe scared of vomiting and ileus. The child is on inotropes, gut ischemia might be there, so I don't want to feed. The child is on a ventilator. What is the hurry to feed? So we are really going away from this type of thought process that I will not feed a child because I am scared. This is an obsolete thought process, and we are going away from it. Then there's another thought process that we'll give vitamin C, we'll give vitamin D, some people say vitamin A. Zinc became a very important thing in COVID times. Everybody was on zinc and saying it's antioxidant, multivitamin is good. Metabolic cocktails started coming in. But you have to understand that all of these micronutrients have no value if you do not give proper nutrition. That means it's like giving coolant to a car with no petrol. How will a car run if there is no petrol? That is, how will a body function if there's no nutrition? You keep on giving vitamins through RT tube, but there's no nutrition, then that is of no use for the body. Body needs, or the car needs, fuel or nutrition to run, not these micronutrients and trace metals. This is an add-on. So get proper nutrition first, and then these antioxidants and vitamins will start working. We have to understand there are different phases of critical illness in pediatric ICU. It's not necessary that patient has to be on inotrope to be said critical illness. So if you see, whenever the patient gets admitted in the ICU, there's an acute injury state or day 1 and day 2, which is called as the acute phase or early period. This is a time where body's catabolism is maximum and anabolism is almost zero. And this is a phase where all of us are very scared to start any form of nutrition. Then comes day 3 and day 7. If you see over here, days 3 and day 7, that's the acute phase or the late period. Here, some of us will start some feeding. It's a transitional period for nutritional administration. And some of us will start, but most of us will say that we can wait for the child to come off the ventilator. We'll wait for the child to be off inotropes to start. And by day 8, it's a late phase. It's a prolonged inflammatory catabolic syndrome. It is too late if you start a feeding by day 8. So what we are trying to say that this acute injury day 1 and day 2 is the period that you should start considering some amount of trophic feeding. Day 1 and day 2. Do not be afraid. You give some amount of trophic feeding. Day 3 and day 7, you start to achieve almost 50% of the calorie requirement. And by day 8, you should reach your 100% of calorie requirement. And this is very important because if you do not give this nutrition in the acute injury itself, the patient's catabolic state will become very bad. There'll be a lot of, in the acute phase, there's a lot of interleukin release, cytokines are being released, and the body needs some nutrition. I'm not saying all nutrition, but some nutrition. And now the data also says that gut microbiome will actually try to help a patient if there is some feed. If you do not give that feed to the gut, the whole system gets damaged. So hopefully I'm clear that we have to start the patient early when the patient is in day 1 and day 2 of illness. The full nutrition support will be achieved by day 8. That is our target. Day 3 and day 7 we'll achieve some, but day 1 and 2 we have to start something. Do not say it's totally we'll keep it the patient NPO. Some amount of trophic will definitely help the child. So I'll keep the things very simple. You should understand what type of diets are available in market and what you should give. So isocaloric diet, that is 1 kilocalorie per ml, is the energy administration of around the defined target. This is the diet that we want to give. 1 kilocalorie per ml. Why it is important? Because this is neither very high, neither very low. If we give high calorie, hypercaloric diet, that hypercaloric diet means large amount of carbohydrates or fat that might cause osmotic diarrhea also. So that is not good. Then there is hypocaloric or underfeeding, which is energy administration below 70% of the defined target. This is a diet which we want to usually give over here, day 3 and day 4. That is underfeeding. Whereas hypocaloric diet is the one which is there in normal feeds. That means that the amount is there 0.67 kilocalories per ml. But you have to understand if we give only 0.67 kilocalories per ml, then we have to give more ml. And more ml might not be easy for a sick child to adjust. So we have to give this isocaloric diets. Then there is something called as trophic feeding. Now, trophic feeding is minimal administration of nutrients which have beneficial effects such as preserving the intestinal epithelium, enhancing immune function, and preventing bacterial translocation. Now, preventing bacterial translocation is very important for us because these bacteria, when they breach the barrier, they become pathological. So we have to give some amount of trophic feeding. Then there is overfeeding. That means you give feed which cross 110% above the defined target. That again has its side effects. And then there is low protein diet. That is, protein administration is kept 0.5 gram per kg per day and below it. Now, low protein diet is again not very much recommended nowadays. What is recommended is start with trophic feeding and jump to isocaloric feeding. These two are the take home points for today. So, if you see the physiology of malnutrition, I'll try to keep it very simple, not make it complicated. So, there's a critical illness, maybe dengue, maybe sepsis, typhoid, maybe trauma, burns, pancreatitis, anything. Whenever it is there, there's release of inflammatory mediators. Act on the catabolic hormones, release cortisol, catecholamines. This is required for supporting the vital organ functions. Whereas there are also release of pro-inflammatory mediators, which is IL-1, 6, and TNF-alpha, which causes catabolism and loss of lean body mass and malnutrition. This is bad if done in excess. And anti-inflammatory are IL-1 and TG. So there's a fine balance between anti-inflammatory and pro-inflammatory. Whereas the child once is turning sick, there's a lot of cytokines released and this takes over. To fight this, we have to give nutrition. Nutrition will maintain this hemostasis between pro and anti-inflammatory. It preserves the body mass and improves the nutrition status so as to fight the critical illness. The moment we find that nutrition is our friend, you will understand you will be able to fight a critical illness much better. Whereas if you think nutrition is your enemy, which we all feel because we keep the patient NPO in sickness due to varied wrong reasons, then keeping the patient NPO contributes to iatrogenic malnutrition in ICU, which causes more harm in the long run. And the patient's stay in ICU increases, ventilation days increases, he is not getting up from the ventilator, he is physically weak. So this all contributes to that. And this is not what we are saying. It has been done in multiple studies that malnutrition in ICU caused prolonged ICU stay for more than 7 days, more than 7 days mechanical ventilation. And this is not some uh, English study. This is an Indian study. And Chinese studies also support the same thing, that more the malnutrition, more the NPO status, more is the length of ICU stay, more is the days of mechanical ventilation. So why is nutrition support very essential for PICU patients? So if you see over here, whenever an illness happens, there is an increase in catabolism and there is a release of acute phase response proteins, interleukins, cytokinins. The stimulus can be even a cancer, maybe a trauma, inflammation, infection, and injury. So what happens in this acute phase response? There is depletion of nutrient stores. Whatever is there in the body, it gets depleted because there is increased catabolic hormones which are being produced, like the catecholamines and the steroids, and there is decreased anabolic capacity. So there is increased calorie and protein needs. But we are keeping the patient NPO. We are not providing anything to the patient other than 5% dextrose. This causes a negative nutritional state in the body and the depletion of nutrient stores happen. Whereas, on the other hand, these patients in critical illness have increased resting energy expenditure, REE. They have fever, they have tachycardia, they have tachypnea, they have increased metabolic demands to fight that particular illness. And if we keep the patient NPO, the patient's nutritional uh, storage will ultimately fall. It's like the bank balance. Your bank balance is going to go into negative, and ultimately you won't have any money, and the whole system will crash. So we have to give importance to our savings. If we do not give importance, we will not be able to fight that particular thing and we'll go bankrupt and the patient will ultimately lose or collapse. Also, there is decreased nutrient consumption. We feel there is ileus, there may be mesenteric ischemia. So whatever nutrients we are giving, they might not be absorbed properly if we do not give the isocaloric diet, if we do not give the adequate protein diet. Then even if we are giving some nutrient, like somebody will say, I'll start with coconut water, we are giving something which is better than nothing, but ultimately it will contribute much less than what is expected from a normal uh, diet or a proper diet as advised by dietitian. So this new decreased nutrient consumption can be due to gastric hypoperfusion, feeding interruptions, or maybe due to decreased appetite also. So this is 2 points which are very important over here, which we neglect is the depletion of nutrient stores and decreased consumption. What is happening is increased expenditure that is out of our hands. That is done by the patient so as to fight a disease. But what is there in my hand is not these nutrient stores to get depleted and give a feed which a patient can adequately absorb. So this is the duty of a doctor so as to bridge the gap between more nutritional demand or more metabolic need of the patient and the less nutrient supply. That is NPO status that we keep. So as a doctor, we have to join these two things because they are going very far. The more the patient gets sick, more is the metabolic demand. But the more we keep NPO, this gap increases and ultimately the patient will collapse. So hopefully, I'm trying to make some sense over here and trying to produce a logic that as a physician, it's important for us to start some amount of feed and bridge the gap between the demand and the supply. Otherwise, the chain will collapse. This is another study which showed that malnutrition is associated with adverse clinical outcomes, longer period of ventilation, higher hospital acquired infection because of the bacterial translocation from the gut, longer PICU stay, and after the PICU, longer hospital stay, and there is increased mortality also. It is not only in pediatric ICU, it is actually well proven in adult studies. There's a lot of stress in NICU, but somehow PICU was little lagging behind in the race of nutrition. So neonatologists have been very smart that they are very, very focused on their nutrition, and it is time a pediatric intensivist or a pediatrician do not neglect nutrition in ICU. Every critical ill patient staying for more than 48 hours in ICU should be considered at risk for malnutrition. This is a universal truth. Any patient who stays for more than 48 hours in your respective pediatric ICUs are at risk for malnutrition, and we have to give them a special diet which is isocaloric, and we have to start it early and we have to continue it even after discharge. Giving a nutrition snapshot in the pediatric ICU. So about the macronutrients, protein requirement is almost 2 to 3 gram per kg per day, and by 13 to 15 years it comes to 1.5 gram per kg per day. Protein requirement is high in PICU as catabolism reaches its maximum level 8 to 14 days after initial lesion. So you may start with a less protein diet in the beginning, but you have to make the patient go in a diet which is rich in protein, because whatever deficit has happened in the first 7 days, by day 8 you should be giving him a diet which is actually very rich in protein. And lipids, on the similar hand, you start slow by 1 gram per kg per day, increase up to 2 to 4 gram per kg per day, and in older children it remains 2 to 3 only. So lipid also in a significant energy substrate, but it is not the only energy substrate. You have to understand proteins are very much required, lipids are also required. Just giving dextrose and semyl MCT oil doesn't contribute much to the nutrition component. We have to give a wholesome diet to the patient. Then the carbohydrates, they contribute 40 to 60% of the total needs. And you should make sure that if you give extra glucose, then it has negative effects too. Lipogenesis and steatosis appears, and hyperglycemia is known to cause more damage to a sick patient. Also, hypoglycemia is equally bad. So you have to maintain a blood sugar level from 80 to 140 in your ICUs. If it is going above 140, maybe you have to decrease the sugar requirement. And if it is keeping below 140, maybe you need to increase the sugar component. And if you're putting the dextrose through peripheral line, then beyond 12.5%, you have to put a PIC line or a central line. Better would be to start RT feeds, because the higher concentration requirement then decreases. So give RT feeds, give adequate amount of carbohydrates through RT feeds. That would be much better than keeping on putting a center line and giving a 25% dextrose infusion or a 50% dextrose infusion so as to maintain euglycemia. So what are the guidelines says? The guidelines say in acute phase, start your enteral nutrition as soon as possible if there is no contraindication to enteral nutrition. Most of the contraindications are surgical. Medical contraindications are very, very less. And in the stable phase, you should reach the 70 to 100% of the requirement. And the recovery phase, you have to give higher proteins, higher diets, so that they build the nutrition gap that has happened in the acute and stable phase. So in the acute phase, you can start with a protein of 1 to 2 gram per kg per day. In the stable, you can go 2 to 3, and recovery phase 3 to 4. Whereas the energy requirement in acute phase might be a little low, but whenever the patient reaches the stable phase, the energy expenditure is more, and we have to give over here more nutritional support. And that is a time in recovery phase we have to give more. At the time patient goes at home, we start on normal diet, but normal diet is not normal for this patient. Normal diet is actually less for this patient in recovery. Normal diet is normal for a normal patient. With a patient who has come out of ICU, come out from the ward, he has a gap, a nutrient gap, and for that we need to give him special or a condensed diet. Also, there is a much demand of these trace metals and vitamins in the management of critical illness and also in recovery. But it should not be like we are only giving syrup zinc, we are only giving vitamin A and vitamin C and multivitamin drops. It has to be supplemented with diet. If you just give this, it means nothing. So there are multiple guidelines. I felt this is the most easy one, that you can start with the enteral feed, which is 10% of the target dose. You look for signs of feed intolerance, which might be as simple as abdominal distension, or maybe as calculated as a gastric residual volume, or maybe if the patient is awake, maybe the nausea. But remember, all these are just suggestive. Nothing is definitive towards the sign of feed or intolerance. So if the patient is having no signs, then you can increase each dose by 10% of the target dose, so that within the next 3 days, you will be able to reach the full target. Whereas there is some return, something is there from 10%, then you can keep the dose. But if the residuum level is more than 3 ml per kg, then you can decrease the dose by half. And in case if the residuum is still persisting after reducing it from 3 to 1.5 ml per kg, if it's still more than 1 ml per kg, then is the time then you really need to consider and find out why it is so low, what is the potassium, what are the other things which might have contributed to it. And maybe after 3 or 4 days, you will start considering parenteral nutrition because enteral nutrition is not getting established. So we should do a daily round specifically for nutrition, and oral or RT or nasogastric should be encouraged as early as possible, and do not find a reason not to give nutrition to a child. You should find a reason, okay, the patient's inotropes have actually started coming down. I'll start the nutrients, enteral nutrition. The patient's PEEP is actually coming down. I'll start the enteral nutrition. So you start the enteral nutrition. That means you should be able to change your habit. Earlier, we used to start enteral nutrition by day 3 or day 4. Now it's important we start our enteral nutrition within 24 hours of PICU admission, or definitely within 48 hours. If you're not starting your enteral nutrition within 48 hours, that means there's something wrong with your hospital or PICU policy. We have to relook at that PICU policy. So, the particular nutritional status, if the patient is severely malnutrition and he gets admitted into your ICU, then at that level, you should check the phosphate level also. And these patients who are severely malnutrition, if you start some nutrition, then refeeding syndrome is what we should be worried about. So, refeeding syndrome will start if you have not fed the patient for 3 days and you start your feeding suddenly, or if a patient who's already malnourished comes into your PICU and you start your feeding within 48 hours, that patient was not exposed to nutrition for long, and you give something, then refeeding syndrome happens. Now, there are many definitions of it. To keep it simple, always check the phosphate level. If the phosphate level is low, that means this is some problem which is going on, and it might be contributing to refeeding syndrome. The other end, if suppose the patient is well nourished or moderately nourished, then consider enteral nutrition and target 70% of the requirement. Protein target should start as soon as possible. That is the early phase, that is day 1 and day 2. Whereas day 3 and day 7 is the acute late phase. In well nourished and moderately nourished, give enteral. Usually, you will consider parenteral only if it is enteral is contraindicated, which can be discussed case by case. Otherwise, we do not, again I'll repeat, we do not consider parenteral nutrition if the patient's ICU stay is expected to be less than 7 days. Then we do not consider parenteral nutrition. We consider enteral nutrition only. And we increase the protein target to 1.3 gram per kg per day. The similar is for severely malnutrition also, but we go very slow if we are going for parenteral nutrition. And in the recovery phase, this is very important, and this is where many nutritional products will start coming into play, that we have to give large amount of calories and proteins so as to build the nutritional gap which has happened because of the ICU stay. Now, these are the two scenarios, severe malnutrition and well nourished. Now, there is one more case, these are obese patients. Now, obese patients, again, you do not have to go by the actual body weight. If you go, then you might be overfeeding the child. You start your nutrition from the ideal body weight, but eventually in the recovery phase, you take the actual body weight and give him the feed. But remember, obese patients, though, are overweight, but they are not well nourished. They might be malnourished intrinsically. So it is important that we give them the essential vitamins, minerals as per the serum levels and treat them accordingly. Do not be fooled by their weight. Or if a patient has been given a lot of fluids, they might look cosmetically edematous. Again, if you give your nutrition as per the actual body weight, you will be in trouble. So, in summary, I simply like to say that critical illness is associated with significant metabolic and catabolic stress. We know now there are three stages of nutritional need, acute stage, late acute stage, and recovery phase. All three are very important. And the most important is in the recovery phase, when the patient is in ward and is going home, we should give our nutrition needs, which are higher than the normal nutritional needs, and they require more nutritional support when they get discharged from the hospital, at least for a period of 1 to 3 months. And this is the time when they will be feeling lethargic, would not want to go to school because they are tired. And here is the importance of giving proper nutritional feeds to them. Then within the ICU, we have to optimize the nutritional support. Do not be scared to start trophic feeds. Enteral nutrition is the route of choice whenever possible, as it is associated with lower morbidity and mortality. Maybe nasogastric might be safer for many. Nasogastric is rarely required, and parenteral nutrition is a rare phenomena in most of the ICUs if you have got a early enteral nutrition policy. It is time to not be afraid of nutrition in PICU, and it is time we do not cause iatrogenic malnutrition in our ICUs. There is a lot of progress which has been made in the technology, in the nutritional requirements, but we as doctors are little resistant. We go slow. It's time we build the bridge between the nutritional knowledge and technological progress. It is PICU is much behind in the nutritional race. If we look at the neonatologist and the adult people, they are very far ahead of us. Now we have a right nutritional product with us. Let's start using it in PICU and post discharge also. So this is just to give you a highlight that blended diet which is there is not bad, but we have a product which might look more appealing. This is my perspective. Thank you. So I have got a few questions. Uh, One question that is being asked is any role of vitamin C and vitamin D in critically ill patients. Now, there was a Paul Marino study which talked about metabolic cocktail. They gave thiamine, vitamin C, and intravenous form in adult ICU, and they actually found a survival benefit. But that's an adult study, and when it was repeated in many other studies, the same benefit was not found. And as I have told in the PPT also, that it's just a coolant. It is not the main driving force. The main driving force is a wholesome nutrition. Whereas if you add these vitamins and trace minerals to it, it contributes in addition to nutrition. But if nutrition is not there, these vitamins and minerals have no value. I hopefully have answered that question. Uh, I'm looking for more questions. Uh, any role of gastric residual volume monitoring and withholding feeds? So gastric residual monitoring is done in many units because it is an objective parameter and we can measure it. But sometimes we there might be gastric slowing and we might be uh, taking in the feeds and the medicines which are being put in, and there might be delayed nutrition absorption. So delayed nutrition absorption does not mean feed intolerance. It means you need to give more time for the feeds to get absorbed in the body, and that does not mean feed intolerance. But it is being used as a what should I say, as a parameter to define feed intolerance. It is little primitive, but it is a simplistic way of defining feed intolerance in ICU. Uh, so, what are the options that are there if you discharge a patient from ICU? So so you can give them blended diet. You can talk to your dietitian, but the dietitian would prefer that in addition to a blended diet, you add some nutritional products which are little isocaloric and high in protein, so as to bridge the gap. And in the market in pediatric ICU, there are presently few nutritional products for that, and there should it should not be very high in dextrose, because if it is very high in dextrose, it will cause osmotic diarrhea also. So it should be high protein, isocaloric, and we should start using such products, and it should be continued for a period of 1 to 3 months post discharge. Start days in ICU and continue it till 3 to 6 months once you feel that the nutritional deficit has been completed. Uh, I think so. I have covered the common questions that were there. Ashish, you want to take over?
Uh, yes, there is another question.
Is there any role of osmolality when it comes to the any preparations specifically for ICU?
Correct, correct. So osmolality, again, I have told that it's very important that if the osmolality is very high, there will be two problems with it. It will cause diarrhea. There will be more feed intolerance, and third of all, the if it is a thick solution, then it will get stick to the tubes, the RT tubes, and the patient might not get the full nutrition. So that's why hyperosmolar solutions are not recommended.
Sir, when we are interacting with few pediatricians, there are some questions coming. Can we give this in the recurrent diarrhea cases, specifically in the trade part? So what's your recommendation for them?
So it is lactose free. This product of yours is lactose free. So this is not a product which is very hyperosmolar, and it can be given in diarrhea also. But uh, it's not a contraindication. It can be given.
So there are one two questions related to products which I am getting from a few of our prescribers, pediatricians. So there are two questions asked by them. One is, what are the chances of diarrhea if you are giving Gruiva advance to the patient? And there is another question to add on to that. If there is any increase in sodium levels if you are giving Gruiva advance.
Okay, so I think so. Study has been done for both. First of all, it's a product which is lactose free. So if a diarrhea is happening, it's not happening due to the product. And most of the times when you start any feeds, little amount of diarrhea is expected because the patient was NPO for a long time. So we should not be afraid of it. So that answers the question one. The question two was, I forgot what is the question two.
Is there any using Gruiva advance? Are there any chances of
So,
increasing sodium level?
sodium, correct. So dilution of a product is very important. You have to understand, like you make ORS, you should know how much you should dilute the product to. So it's depending on the age and the volume, you have to add the number of scoops. So 2 scoops or 3 scoops in 170 ml or 180 ml, depending on the age. If you miscalculate the scoops, then there is a chance that you might if you give less scoop in more water, maybe hyponatremia, or more scoops in less water, maybe hypernatremia can happen. But if you follow what is written in the chart as per the age, then there should not be any problem.
I think, sir, there are no more further questions. So, with this, we come to an end of our webinar. But before we conclude, I would like to express our gratitude to all the attendees for their participation and contribution to today's webinar. Your dedication to enhancing pediatric care is truly commendable, and we hope this session has provided valuable insights that will benefit your practice. And sir, thank you very much for generously sharing your time and expertise with us. Your dedication to advancing knowledge on said topic is commendable. Thank you once again, and we look forward to continuing our journey towards pediatric healthcare through enhanced understanding and implementation of specialized nutrition. Thank you very much.
Thank you. Thank you. Thank you. All the best.